next speaker is Dr. C. Wavikar. He's going to be talking about range of vision with PC IOLs, my experience.
Thank you very much. Good afternoon, everybody. So I'm going to talk on range of vision with PC IOL. So these are my financial interests. So when we started like few years back, we used to say that cataract is a refractive surgery, but today it is not only refractive surgery. A patient wants to have very good vision at different distances, at most of the distances. And if we try to clarify further, there is quality of vision, range of vision, and it should be without glasses. Without glasses is given. If there is no emmetropia, then the matter ends there. It is essential prerequisite. Now, range of vision and quality vision cannot be separated together, but let's see how they work in comparison to each other. So, what are the current visual needs? We have people with different professions coming. The most important thing is understanding the profile of the patient. So, if he's a dentist or a person who is doing a lot of tailoring work, then ultra near vision, which is about 1 feet, is zero point 0.5 to 1 feet, is very very important. Then the of course the reading, including some tablets and mobiles and all the small house chores which are required. You require a good near vision. Then intermediate vision, car dashboard, computer, and musical instruments, etc. For that you require this intermediate. Then there is distance intermediate vision, which is around 8 to 10 feet, for where you are doing watching the television. And lastly is the distance at infinity, which is essential for driving and sports. So, intermittent tasks are often done at arm's length, and that was a study by OSHA which said that 40 to 80 centimeters was the ideal distance where everybody wants a crisp, vision, and that is the least compromisable range after the distance, and therefore most of the lenses started concentrating on this. But as the time when we got EDOF lenses where there was extended depth of focus, and we are marching on. So monofocal, as you know, patient does not require glasses only for distance. Then there was a bifocal, which we used to call multifocal, where computer working on computer and tablet was a problem. Then we have got trifocal, and it is just going on and on where the range is increasing. Now, what are the changes over the years? The balancing act. Number one is that we shifted from refractive to diffractive, and then we shifted to refractive, diffractive, apodize, which increase the range as well as quality of vision. Then we are doing jugglery with the number of rings. So now these are the lenses with different types of number of rings. As you increase the rings, as you increase the step height, as you make them truncated, you are getting different kind of vision. So what has been thought is that today perhaps all the lenses within the rings, number of rings between 8 to 15, they are the ones who are working the best in terms of quality of vision for distance at night, and in terms of um, quantity of vision. Uh, Then we come to the central zone. As you can see that initially the central zone or the bullseye was very small, but when the angle alpha came into picture, everybody started realizing that we require a bigger central zone. And as the time is going on, we are increasing. But most of the current lenses have a central zone of around 1.6 to 1.2 millimeters. Now there are some lenses with a bigger zone, that is symphony, synergy, vivity, where the bullseye is more, but then there is a compromise on the near vision. So it is important to understand the profile of the patient and act accordingly, choose the lens accordingly. Then comes the design. So we had bifocal lenses first, then trifocal, and then quadrifocal, where the number of diffractive rings and their height was increased. And in quadrifocal, the last step was truncated so that the vision, that light was parted for distance, thereby improving the quality of vision for distance. Then let us look at the defocus curve. The one of the first trifocal lenses came is this lens Zeiss acrylysatry, where in addition to the distance and near, the graph which is at the defocus of say 1.5 to 2 minus was lifted slightly. And then came fine vision lens, where it was a hydrophilic model first and hydrophobic model first, which showed further improvement in the that intermediate important zone. Then came panoptics, where there was further improvement in the zone. But all these patients somewhere or the other kept on complaining about halos. So you will get one of patient where the halos and glare will be there at night. And then there was a symphony. Again, a ring issue was there, but intermediate zone was good, but patient required reading glasses. And then we have synergy, where the situation is improved further. So like the way it is going, we are improving upon the results, and patients are getting not only good quality of vision but better range of vision. Same VVT comes in the same bracket. But what we have today is the geometric and geometric plus. It's a new concept and it's very interesting concept. Dr. Sonu Goyal has made my life easier. So we had twin set lenses before, but one was dedicated extremely for the distance, and the one was too much for near. And then both the eyes had to work together. In case of geometric, that is not the case. The in geometric lens, even though it is meant for distance dominance, the near vision is also quite good. And in case of geometric plus, even though it is meant for near, the distance vision is also quite good. And the temporal summation of the two lenses becomes very good, and the range of patient vision patient gets is quite good. Now if you look at, there are small two bumps in the center. Okay, these two bumps are important. So these are the distances like 8 feet, 10 feet, or something beyond the dashboard. These are the distances where we do not require very fine vision. We require gross vision. But the quality has to be good. Now these two small bumps are giving that quality of vision, and therefore truly this lens is capable of giving very good range of vision all throughout the distances. Of course, our experience is quite limited, and we will have to see in future how this works. But right now, the results appear to be quite promising. And this is what I was talking about. Dr. Sonugal already showed this slide, so I will skip this. And again, as the pupil becomes small, on the one side is geometric lens. The black graph is of distance. As you can see, when the pupil goes beyond 3, the light required for given for distance increases, whereas in geometric plus, the yellow is the one which is for near, and it is from the beginning it is around 35-40%, it is, to be precise, 38%. And as the pupil dilates beyond 3 millimeter, the energy for near drops down, because when you're reading, the pupil definitely becomes smaller, and for distance vision the pupil is larger in size. So the lens works on the basis of temporal summation. Now there is another concept that if the person is working exclusively in the near conditions or room light conditions, we can implant geometric plus in both the eyes. But these are the early days to come to that conclusion. Right now, let us stick to geometric in one eye and geometric in plus eye. The another important point is that there is no need to understand dominance. So it is not necessary that you have to put a geometric lens in dominant eye and geometric plus in the non-dominant eye. Because as I said already, that even though it is geometric meant basically for distance, the near vision is also quite good. And same true for geometric plus, that even though it is meant for mainly for near, the distance vision is quite good. So there is no need to check dominance of the patient. Now again, this slide was showed by Dr. Sonu Goyal. I will what I would like to comment here is that even though all these lenses show almost similar graph, it is very important, therefore, to understand the profile of the patient, what are his needs, and then choose a lens accordingly. And all these lenses are giving us different options, different combination of ranges of vision. We are kind of spoiled for choices, but one way it is good also, because we can give patient exactly what he wants. Thank you.
Thank you, Dr. Wavikar. I would have these questions for both you and Dr. Sonu. This seems to be a completely different revolutionary concept. All along, we have been thinking about playing with the power of the intraocular lens that's being placed in the eye. But now it's more a light distribution which is being talked about. How do you think this is going to be better than comparing, say, putting in a lens with plus 3 ad and a plus 3.5 or a plus 4 ad. Um, Conceptually, you will think that that's what will work better rather than just playing with the light conditions.
Yes, sir. I think it will work better. It is not that we have implanted too many lenses, but whatever patients we have done, and binocularly, it looks like they require little less the light for reading with these lenses as compared to the competitors. So this light distribution seems to be helping the patients somewhere.
Your inputs.
So I think that's a very nice question. Even I also was into that thought process. So very limited experience of maybe couple of cases that we have done so far. So I think that light distribution would take care of that loss of contrast, which actually is happening with most of these presbyopic correcting lenses. And an ad of 3.5 is just trying to give you a magnification, but that doesn't give you actually the contrast which is actually required. So I think with the graph and the defocus curve that they're trying to show, so I think the uphill with the near with the geometric plus, so that actually is not compromising the distance vision, though the light distribution falls, but actually gives you a little more on the near part. I think the transition like from multifocal to trifocals was basically based on the light distribution, and that's why they were able to create that the intermediate kind of light distribution curve. So I think it's a way forward towards that only.
I think the most developments in multifocals, trifocal technology is towards reducing the amount of dysphotopsia. And the less the light that is not utilized, that is the one which is causing problems. Like when we went down from 82% light utilization to 88% light utilization, even our conventional trifocals had an advantage. What is the light utilization in these cases? Is it much higher?
89%.
Huh?
89.
Okay, maybe that's one of the reasons why.
Slightly more, yeah.
And the other concern I had was, the central diffractive rings are only in the central 3 millimeters or
3.2.
3.2.
Yeah.
So, some of the lenses we are familiar with went from 3.6 to 4.5 millimeters because they said that when the pupils expand, in mesopic conditions, the near vision will be dropping down, and that's our experience also. That's why they talk about a full diffractive lens. Here, actually, you have gone ahead and reduced the zone of diffractive rings. How does this work in dim light conditions as far as the near
Yeah.
vision is concerned?
So again, it's a very interesting question. See, right now our experience is quite limited, but I think that we will have to compare the lenses, the quality of and range of vision vis-a-vis the pupil size, and then we'll come to know whether 3.2 is good enough or really require 4.5. So it's too early, but I think that there will be some type of patient for whom this will be a good option, at least.
So maybe in these patients, the greater light distribution for near will help. Definitely, I think we cannot substitute the increasing from 3.25 to 3.5 with changing in the light distribution. They are two totally different principles. But in mesopic conditions, when the pupil dilates, then definitely distance vision will be better. But for near, the increased light distribution for near probably will help. And ease of reading, more importantly,
Yes.
the speed of reading and the ease of
And
reading.
so inherent to these lenses is a differential light distribution. Do you think that doing a bit of a micro monovision, in the sense that making the non-dominant eye a plus 0.5 will add to this and increase the quality of vision?
So
I
Improve
I
don't
light.
think
think
so. So in this
the
patients, we
ad
have
is pretty good as such, I
yeah.
think. So it's not a question of doing a monovision there. The only thing is that in dim light conditions, that's where, see, all these lenses are working very well in good light conditions. All trifocals are. So it's just a question that the light
No,
distribution, if you increase that for near, I think that will summate it up for the when there is a low light condition, then therefore you can have through the day good outcomes. So I don't personally think, I don't have much experience. Actually, I haven't implanted a single geometric so far, but matlab from a context of the way the lens is designed and all, I don't think we'll need to do a micro monovision, because you are with a +4, you are like here. So if you're doing a monovision, like that's like a +4, so that's not the optimal distance that is there.
Yeah.
So I think
I
it's the
think
light which is basically low light condition which is causing the trouble in other lenses which they tend to address by doing one eye giving more light for near in dim light conditions.
So up till
I
now,
think
I've had no surprises regarding refractive error. But suppose we get a patient where we are left behind a plus 0.25, plus 0.5, then only I will consider mono micro like mono micro vision. Otherwise, not.
Wavikar, can we have that slide which we were showing for that pupil size?
You know, obviously, all along with all the multifocals, trifocals that we have been buying vision for all distances using the currency of contrast. So, whenever you talk about vision for all distances, there's the contrast which goes down. This lens, I think, is a fairly disruptive technology in the sense that it's not talking about just power or just the number of rings or something, but it's talking about light distribution, which has not been addressed by any of the other lenses which have been currently available to us. So, of course, it's very initial experience all these surgeons are sharing, but over time will tell us that whether this is the right way to proceed. Yes.
Yeah.
Sorry.
That's it.
Oh,
Dr. Sonu wanted to explain something.
yeah, let-
Mike.
Efficiency, na, sir? So if we actually see the diffractive efficiency, as the pupil size increases, it increases from almost 40 to 60% from 3.5 to 4.5. But there is hardly any fall if you see from 3.5 to 4.5. It's a very, very minimal fall in the diffractive efficiency. I think that is the key for that, the size keeping close to 3.2.